Endotalks podcast, a podcast about the latest research on endometriosis. Good afternoon, everyone. Thank you for tuning in to yet another Endotalks podcast. This is the December 2025 version of our podcast, and we have the honor to have with us Gil Dubernard, Professor Gil Dubernard, to talk to us about his team's research, mostly around the use of high-intensity focus ultrasound in the management of rectal endometriosis. Gil, thank you so much for being with us today.
Thank you to give me the opportunity to take part in the Endotalk, and welcome in Lyon in Croix University Hospital in our referral endometriosis center.
Thank you so much. So I'll start quickly by a quick introduction about Gil. We all know him, but he needs no introduction, but I'll say a few words about him. He was trained in obstetrics and gynecology with a specialization in surgery in Paris between 1997 and 2007. He did his PhD thesis in 2008 on the influence of fetal microchimerism on mammary adenocarcinomas associated with pregnancy. Then slowly he shifted his work towards the diagnosis and treatment of endometriosis. He joined the Croix-Rouge Hospital in Lyon, France in 2007, where he was appointed in 2010 as a university professor and head of the obstetrics and gynecology department in 2025. Since then, Gilles' work has been increasingly focused on the diagnosis and management of endometriosis. He has developed a new technique for diagnosing endometriosis, which is known as 3D rectal sonography, which enables the consideration of management approaches alternative to surgery for rectal endometriosis. With his team, he carried out the first global phase 1 study on the treatment of rectal endometriosis with focused ultrasound in collaboration with EDAP TMS company. Gilles, without further delay, the paper that we will be speaking today is called Evaluation of Rectal Endometriosis Treatment with High-Intensity Focused Ultrasound versus Surgery, a clinical retrospective multi-center trial. So if you could please summarize in a few sentences the main points and the main findings of this paper, please.
Sure. So first, this study, as you said, is a multi-center study. So we performed the HIFU treatment was performed in our department, and the surgery was performed in the team with the team of Horace Roman in IFE in Bordeaux. So the first point is that we demonstrated in both groups at 6 months a significant improvement in acute pelvic pain, diarrhea, tenesmus, and penile defecations. Of course, according to the study design, it is not possible to compare the magnitude of symptoms improvement between the two arms. But this fact is interesting to underline. These results are also, it's important also to note that these results were observed that in the HIFU arm, only HIFU was performed on deep infiltrating endometriosis. In comparison, in the surgical arm, the surgery was a complete surgery. Mm-hmm. So that is another point which needs to be underlined.
Sure.
The third point is a significant improvement in dyspareunia. Although vaginal involvement was significantly more frequent in the HIFU arm than in the surgical arm, we have 73% of vaginal involvement in the HIFU arm and only 36% in the surgical arm. We observed a significant improvement at 6 months of the dyspareunia only in the HIFU arm. We all know that the vaginal involvement on MRI is often overestimated, which can explain partly these results. But also the HIFU treatment can also explain this improvement because most of the time when you have dyspareunia, it's could be explained by the rectal involvement, but it's not only the rectal involvement. You also often have the torus uterinum involvement, the proximal uterosacral ligament involvement, and sometimes the posterior vaginal cuff. So it's all this posterior deep infiltrating involvement which explains this dyspareunia. And when we perform an HIFU treatment, the first treatment starts at the lower margin of the lesions and progresses to its upper limit. So the first area treated by the HIFU is the lower limit, which include vagina, uterosacral ligament, torus, and the lower part of digestive lesions. That can explain these improvements. Moreover, of course, we do not have any colpotomy, no vaginal suture. So patients have probably less apprehension about resuming sexual activity. The fourth interesting point of this study is the low morbidity. We did not observe in both arms rectovaginal fistula, which was a major risk, we know, for surgery, but either for HIFU treatment. Why? Because HIFU treatment, the first shot is at 3 millimeters from the mucosa, and the temperature reaches 85 degrees. So the risk of fistula could be high. But the probe we are using and the technique which we use for HIFU is the same which is used to treat prostate cancer. And more than 70,000 men have already been treated by this technique. So it's a robust technique, and the risk of fistula is very, very low for prostate cancer, either if the patient had previously brachytherapy. So even if it was a risk, and I was afraid about this risk of rectovagina due to the thermal lesions, in fact, the risk is really limited, and we did not observe. We have now more than 140 patients, and we have no case of rectovaginal fistula. So that is the point. The other, we didn't observe any grade 3 complications in the HIFU arm compared to 10% in the surgical arm. And remember, it's a team of ORA, so it's probably one of the most expert team worldwide. So this risk is lower after HIFU, and the risk after surgery is quite low due to the experience of this surgical team. According to the grade 2 complications, we only had 3.3 complications compared to 22% in the surgical arm. And the last point is probably the worst complications, long-term complication, is dysuria. We only had one case of dysuria in our series compared to 16% in the surgical arm. And the last point is the hospital stay, which was significantly shorter. 92% of the patients left hospital at the day after the procedure in the HIFU arm, compared to 90% who stayed 2 or more nights in the surgical arm. So now all the HIFU treatment are performed in an outpatient basis.
Okay, that's brilliant. So that's very interesting and impressive results. Congratulations. I wanted to ask, because many of us may not perform this procedure, how does it actually work? I mean, what is the mechanism of action of HIFU in rectal endometriosis?
I can explain to you the procedure. I can describe the procedure first. The procedure, the probe has 2 transducers. One is for imaging, and it's a real-time procedure. So at the center of the probe, you have imaging transducers to localize the lesions. And around these imaging transducers, you have the therapeutic transducers. And to generate the high intensity ultrasound. So we use low frequency but high intensity ultrasound. It can be 10,000 times more. The intensity can be 10,000 times more than the intensity which is used for imaging. It's a robotic procedure. That means that the treatment planning is completed before the shots begins. That is really important to note. All is scheduled before the shots. all posterior deep infiltrating endometriosis, including the rectal lesion for sure, but torus uterinum, uterosacral ligament, and when visible, the posterior vaginal cuff can be scanned. So the software divides the lesion volume into slices spaced 1.7 millimeters apart. Then on each slice, the physician will delimitate the boundary of the lesions, and the device determines the number of shots needed. The HIFU are focused on the lesion with a millimetric precision, and the volume of each thermal lesion is nearly the volume of a grain of rice. And we will repeat these thermal lesions to complete all and to treat all the surface of the slice of the lesions. And then we move to the next slice. Usually we will have between 5 to 15 slices, and each shot is 1 second. So it's very short. So that is the procedure performed either under general anesthesia or under spinal anesthesia. What we observed on the tissue. In fact, as you know, we do not perform surgery, so we don't have histology. We have done some surgery after the treatment. We have done 140 patients in 8 referral centers in France. So some surgeries has been performed after, but we didn't observe any difference in the histology except necrosis, fibrosis. So usually, as in our safety study, we had an MRI at day 1. What is observed at day 1, we will observe an edema and a necrosis on MRI T2 hypo signal on MRI is observed at day 1 with edema. And after a few months, we have a significant reduction of the volume of the lesions. And the tissue is usually observed is a fibrotic tissue, no specific vascularization, not anymore vascularization in the tissue, which has been treated.
That's brilliant. That's very interesting. Thank you. I wanted to ask you about, you mentioned that it's not only the rectal lesion as such, but it could involve things that like the uterosacral ligaments, the torus, the vagina. Indeed, according to your paper, there was almost 70% of the patients had uterine torus, deep endometriosis as well. I wanted to ask about the potential implications of lesions that extend laterally, meaning towards the area of the parametria. These excluded from your technique, meaning nodules that exclude really laterally? Because we do know from experience that if we have, for example, some parametrial deep endometriosis lesions, they may involve and cause problems and strictures with the ureter. Are these nodules with lateral extension suitable for HIFU treatment or not?
It's a really good question. Our contraindications, as you know, we are CE marking for the focal one is CE marking for the treatment of deep infiltrating endometriosis with rectal involvement. So we are allowed to treat rectal lesions, but other deep infiltrating endometriosis. Our contraindications is first the sacral nerve infiltrations. Not really because the risk of to create a lesion because it's too lateral, lower than most of the time lower than the rectal location on the uterosacral levels. So there is no risk of lesions of these nerves, but for sure the effectiveness of the treatment will be disappointing. So the first is there is no indication when there is a sacral nerve invasion. The other contraindication for us is parametrial involvement. Okay, and of course, if there is a parametrial involvement with ureteral infiltration and hydronephrosis, it will be a contraindication. You will not, there is a risk of thermal lesion as the ureter is huge. Usually, in this case, when there is hydronephrosis, maybe you can create a thermal lesion. So for sure, it's not a good idea. So that's the limitations. And in our studies, we also multiple digestive locations were also contraindications. It's not anymore the case because, I really think that the most symptomatic digestive location are the rectal locations. Of course, if you have an occlusion of the sigmoid colon, huge nodule with an occlusion, you will need the surgery. But most of the time, when there's a rectal location and a small sigmoid locations, the small sigmoid location is not very symptomatic. So now I will include patients with double locations. We will first treat the rectal locations, and after we will see, depending on the symptom evolution after HIFU, we may consider additional surgery. So that is our contraindications. After, to be more precise, I think, as I told you, the risk to have lesion of the sacral nerves is limited, but you are right. When you have lesions laterally, you have to be careful to the ureter and to the hypogastric nerves, plexus nerves. We resumed treatments last week, and I treated a patient with rectal locations and the left uterosacral ligament lesions. The maximum lateral compensation was 70 degrees. I think a higher value may be dangerous for these hypogastric nerves and ureters. But it's quite rare to have a lesion which is so laterally. So I think most of the case can be treated by this new minimally invasive approach.
Okay, thank you. Now, this was also, I read that very interesting paper a few times, and you make an interesting statement based on the fact that almost all of your patients in the HIFU arm had evidence of deep endometriosis outside the gastrointestinal tract. And you actually say that in your paper you state it may be tempting to conclude that all endometriosis lesions except rectal nodules have negligible impact on pelvic pain, sexual function, and digestive disorders, so surgeons could focus solely on management of rectal endometriosis. On the other hand, we have a lot of studies, as you rightly say, to demonstrate that the completeness of the excision brings huge benefits. How do you explain this? Elaborate on this comment a little bit more, if you could explain this to us, please.
Yes, this statement was made cautiously, okay? Since the results may be partly explained and influenced by patient selections. But as I told you, in my opinion, and it seems to be confirmed by our studies, the most symptomatic location are the posterior, the IA. I don't know if the role of superficial endometriosis associated to deep endometriosis in the pain symptoms. I don't know. I think, to my knowledge, it was not demonstrated that superficial endometriosis can be explained the pain of in patients. It's mostly the deep endometriosis. So superficial endometriosis can be associated, but I think the most important is to focus on deep endometriosis. Of course, if there is other locations of deep endometriosis, we will not be able to treat. We can discuss about that in the future, but I think it's not possible to treat yet bladder endometriosis with HIFU, not with our probe, but even with a transabdominal probe, it's not possible to treat at this. I think now at this time these locations. So if patients have urinary bladder locations, we will perform the surgery. We will need to perform the surgery at the same time, or maybe or later. We will see. Exactly the same if patients have diaphragmatic muscle locations of endo. For sure, they will still have these symptoms after the HIFU treatment of rectal endometriosis. But what could be interesting for this type of location? We had this discussion several times with Horace. And he doesn't want to perform at the same time the surgery of diaphragmatic muscles and the surgery of rectal location, because if you have cage, you can have a severe infection of the lungs and as well as the peritonitis. So with our approach, we will be able to combine IFU treatment of rectal endometriosis, as we don't have risk of fistula, and there is no lesion, no digestive lesions on surgery, and perform maybe at the same time a robotic surgery of diaphragmatic muscle location.
That's interesting. Is it something that you have done, these combined procedures? Because these are possible, right? To do combined procedure.
Not yet, not
Hmm.
yet. But I have several cases with bladder locations and rectal locations, and of course, rectal location and diaphragmatic muscle location. And some I schedule I will do it. My objective is to perform a complete robotic treatment of deep endometriosis, combining robotic IFU treatment and robotic surgery as we all use with Da Vinci or something else. So I didn't perform the cases yet because in our studies, we only included patients with rectal location most of the time. So we didn't want to combine this type of treatment.
Of course.
But I think it's possible, and we don't measure the risk of complications.
Hmm.
Except if you perform, I think, at the same time, rectal IFU treatment, hysterectomy, and bladder
Okay.
treatment. I think, we perform the thermal lesions, and if you perform just after the hysterectomy and the suture of bladder, I think you measure the risk of fistula between.
Officially.
I think it's not a
Between the
good idea.
organs, yeah.
But if you leave the uterus, I think you can perform the IFU treatment of rectal endometriosis and perform a bladder surgery and, of course, diaphragmatic muscle surgery.
That's an interesting approach. I would be interesting to see that. Tell us a little bit about the practicalities of this approach. Lots of the colleagues may be interested to incorporate in their practice. Is it available at the moment, readily available in many countries in Western world? How does one get hold of this?
At this time, it's only in France, but it was only studies. And as I told you, we just resumed treatment last week. So I performed three patients last week. But since March 2025, we have CE marking. So this allows us to start an IFU program in all European countries as in India. And our training curriculum is ready, and so we are ready to start. In fact, we are limited physicians, practitioners trained to this approach. So we will need to support the new physician in their learning curve. So that means we will probably start in 2026 in a limited referral centers, endometric centers in Europe, to start maybe one or two in each countries. We'll start slowly, but we hope after to have all the other departments we will be trained to this new approach to help us to develop this new approach. But
Mhm.
at this time, we are three or four in France. We are ready to start to start and support the clinician. So that's why we have to start slowly. But our objective is to develop in 1 and 2 years many centers in Europe, in India.
That's great. And in terms of the cost, do we have any idea? I know you said it's not available in many, areas and all that, but do we have any idea how it compares in terms of cost? Say, if we compare it to, rectal endometriosis surgery.
Um, this procedure for sure appears cost effective. The duration of the procedure is the mean duration is 35 minutes, including introduction of the probe, scanning of the lesion, planification of the treatment and treatment. So it's 35 minutes. The mean duration in the OR, including anesthesia, is 85 minutes. So it's very short procedure. And as I told you, the last 80 procedures were performed as an outpatient basis. So, and the mean duration of the sick leave was 7 days, and no severe complication, no grade 3. So that means no re-hospitalizations to treat severe adverse events. So this procedure is cost effective. For sure, it's different than the surgery. The maximum of cases we have done in one day was performed at Tivoli Clinic with Thomas Denis, and Thomas performed 5 cases in one day. So, there is no comparison. It's a procedure that is very short. So we have to start the discussion. In France, we will start the discussion with, the health authorities to know how could be the price of this procedure. We did not have started this discussion yet. But, there is no comparison between the cost of the HIFU treatment. You have the cost of the development, the research, and you have everything, but it's not the same as a surgery, for sure.
I understand. You mentioned about the lack of histology. You said that you've done some cases where it was required to do surgery after that. Do you think that the lack of histology routinely is an issue, is a limitation of the approach? I mean, the risk of malignancy in those cases is very small, but do you think that the lack of histology may be viewed as a limitation of HIFU?
I am working on endometriosis for more than, as you said, for more than 20 years. And the number of cancer diagnosed after surgery, I do not remember, it's less than five cases, and most of the cases are ovarian, if I remember. So this risk, I think, this lack of histology preoperatively, I think that is not limited. Cannot limit the development of these procedures. Most of the time, the clinical presentation is typical of posterior deep infiltrating endometriosis with rectal involvement, and moreover, all the patients will undergo MRI before HIFU treatment to localize the disease, the lesions, to specify the upper limit. And if there is any atypical feature, of course, we will have a discussion. We have every week a multidisciplinary meeting, and we discuss all the cases for surgery and, of course, for HIFU. So if there is any atypical feature, the surgery will be preferred.
Of course. Understood. And a few things we already discussed about training. You mentioned that there is a training program that is in place. Tell us a little bit about the future in terms of any ongoing research. You mentioned some of your plans. Where does the future lie, you think? What are your plans in terms of developing this technique?
First, it depends. The next step I will explain to you later, but if first we have to, the clinician, the physician has to adopt to be convinced by this result. So it's a disruptive approach. So we are all surgeons, so and we are limited of surgeon sonologists, and I think it's really interesting to have these double skills. And it's not difficult, in fact, to diagnose rectal endometriosis. So for sonologists who have experience in endometriosis, it's easy to diagnose rectal endometriosis. It's more difficult to diagnose the other locations. And like uterosacral ligaments, and if we want to have to improve and to have better results after this type of treatment. We have to treat like we perform in surgery. We have to perform a complete HIFU treatment of posterior deep infiltrating and infiltrating endometriosis. So the
Mhm.
learning curve for this for rectal endometriosis and this is between, I think, 20 to 30 cases. It depends on the experience of the sonologist and the surgeon sonologist. We will be able to upload very soon the MRI on
Mhm.
the device, so it will help us to to better localize the other location. So I think it will help to reduce also the learning curve of the physicians. But I think with between 20 to 30 cases, it's not difficult. I am a surgeon first, and
Mhm.
I started my experience in ultrasound imaging 12 years, 15 years ago. So it's not. I have experience. I see a lot of cases, but I am not a radiologist. So
Mhm.
that's it. That's what I can say about the learning curve. After, what will be the next steps if you want to know what I am imaging for the
Mhm.
future
Yeah.
of endometriosis, deep endometriosis? I think what will be very interesting, is to start a study with this probe on patient infertile with posterior
Mhm.
external adenomyosis, with or without rectal involvement. I don't mind. But we have most of the young cases, young patient, infertile young patients with a failure of everything, IVF, anything. Most of the time, when they have severe endometriosis or adenomyosis, the location is on the posterior wall, external posterior wall. I don't know if it could work, but we need to test. And
Mhm.
with the precision of this treatment, we will be able to treat the posterior adenomyosis, and we will and with no risk of thermal lesion of the endometrium. So that if you want, if I had the money to perform a study at this time, I think this study will be the first one I will do, because we have the probe. We know that because we perform studies with my colleagues of attenuation of adenomyosis. After hysterectomy for adenomyosis, we assess the attenuation of the ultrasound by adenomyosis. So we know exactly which type of intensity we have to use to treat this adenomyosis. So I think it would be interesting to evaluate if we could improve the fertility of these patients. That will be wonderful. The other thing I would like we are working on is to add AI to
Mhm.
assist physician with limited experience in ultrasound imaging to better localize the lesions. That would be interesting. So AI in every congress, AI is
Of
everywhere
course.
in imaging. So I think we have to work and to try to upload AI on this in our program. And the last feature, but is very soon, as I told you, is a combination between robotic surgery and robotic HIFU in order to achieve a fully robotic treatment of deep infiltrating endometriosis. That will be wonderful, I think.
Think these are so valid points that you make there. From my point of view, I think you mentioned very clearly that the development of the surgeon sonologist is a new topic that I think is ever so important. And I think the younger generation of people that go into endometriosis do appreciate that it is a very useful skill to be able to scan as well as operate, because that gives you the opportunity to actually know in detail the depth of the lesion and all that. So I think the immersion of the surgeon sonologist, as you rightly said, is an important topic that we are seeing more and more in our practice. And I think certainly the incorporation, as far as I'm concerned, the incorporation of those new approaches and combining them with other modalities, such as you said, robotic surgery, is certainly going to be most useful in the benefit of our patients. So I'm really looking forward to, once this new approach hopefully, becomes a bit more standardized and available, to see what place it will take in the modern management of endometriosis. But certainly your results, as far as I'm aware, are very, very interesting. And I really congratulate you on that.
Mhm. The place we have to define all together, in scientific society, what could be the place of this new approach. Of course, it will not replace all the surgery of deep endometriosis. It's not possible. But as there is no risk in appearance, we can try for suitable location this new approach in first line. And if it works, wonderful. If it's failed, we will go to surgery after. If there was a risk of fistula, we will not continue this approach, but there is no risk. So I think it could be interesting for suitable lesion, and we are working on the good to define the very good cases to start this new approach in first line instead of surgery. I think in the future.
Yeah, careful case selection is so important, and the low morbidity, low complication rate is certainly a big benefit. Um, I'm more or less satisfied with what I heard. Do you have any last comments to make as we're approaching the end of our webinar?
Right. Thank you very much. And of course, I hope to continue to develop. I need many of our young colleagues like you to help me to be convinced and to want to help me to develop this new approach. Because of course, the idea is not to perform these procedures in Lyon or in France. We have to the widespread of this new approach we have to do that all together. And it's my main objective.
Thank you so
Thank
much.
you very much.
Thank you. It has been a great pleasure to speak to you. Carry on the great work that you're doing, and I'm sure we will catch up very soon in one of those international conferences as well.
For
Thanks so
sure.
much.
I don't miss any international conference, as you know.
Oh, sure.
Bye.
I know that. Okay. Thank you so much. Enjoy the rest of your day. Thanks to
Yes.
everyone for joining Endotalks podcast. We will see you soon again. Thank you.
Bye.